Record on this computer. Okay, good evening, ladies and gentlemen. Welcome to another session of Thoracic Gurus. Really proud to announce that today is our 70th lecture of this series. I didn't even know that there were 70 topics in thoracic surgery, but I think we've done very well. And I think Dr. Mithiran, you will be hour 149 and hour 150. You have the pleasure of doing the 1.5 century for us.
Thank you. Thank you very much.
It's such a pleasure to introduce Harish again with us. As you all know, Harish Mithiran is a consultant thoracic surgeon at National University, Singapore, a dynamic young surgeon doing very exciting work, doing a lot of chest wall surgeries, a lot of VATS surgeries, and he is involved with us in the on the Asian platform for teaching VATS across the various countries in Asia. Welcome once again, Harish, and we're looking forward to your talk on complications, postoperative complications and their management. Take it away, it's all yours.
Thank you very much, Dr. Khan. It's a pleasure to be back here to give this talk. So when I took this topic on with Dr. Khan, I went through it and I went, oh my God, this is going to be like a 500 slide presentation. So I thought maybe I could break it down and go to things that we actually generally really see a lot in our practice. And it generally comes down to 2 or 3 main complications that we always deal with. And I think you've come up with, there have been many talks on postoperative air leaks, complications like empyema, bleeding, and a lot of theory behind that. So I wanted to go more on a clinical level with a bit of evidence. And also I wanted to show, what I've been through and how I've dealt with it in the future. Some interesting cases that I put up there, was difficult to manage. And I wanted to just share it with everybody else. So I wanted to start with Isaac Asimov, who is a professor in biochem. He passed away, I think, in 1992. I looked it up. And he said this nice thing: life is pleasant, death is peaceful. It's the transition that is troublesome. And really, when we do surgery, generally, most of the time, it's straightforward, but we definitely encounter a lot of mid-ground and complications, and it's how we're going to take it from there and deal with it. So I decided to just focus on lung resection, and also on top of that, focus on complication lung resection, just focus on a certain few areas that I'll go into. But before that, the most important thing is, management of a patient is actually preventing these occurrence, and we have to optimize them. And one of the main things is that when we see patients and we think that, okay, how do we deal with this? It's going to be a complicated patient or not. It's actually looking at their pre-op selection. And one very important thing is that we do the basic workup and we thoroughly screen them. And it's very important for all surgeons before we get in there, we get them to do a lung function test. And if the lung function test is not very good, we get them to do exercise testing. And if they're in the borderline level, and most of them are usually, at least in my practice where I see, they are generally very chronic smokers and stuff. If they're borderline and we know we can do curative resection for them, we tend to be very aggressive with our pulmonary rehabilitation for them. And we need to optimize them very well. Of course, cigarette smoking, you tell them generally to stop, but I think about 90% of them don't. But you still must encourage them, get them on patches, get them to see put them in the smoking cessation clinic and go from there. And, you got to look at them. And again, most of these people that come to us generally have some sort of diabetes, hypertension, and they need to be managed optimally over there. Get the nutrient level up. In Singapore, generally, most of them are quite well nourished over here. But the cases that we see that are very malnourished, make sure we get them, get the nutrition up. And again, it comes hand in hand most of the time. Lung issues, they generally, some of them have, or most of them, I'd say maybe 50% have some sort of cardiac issue. And you need to really evaluate their cardiac status, because this is one of the main causes of the morbidity at the end, mortality morbidity post-lung resection. So intraop, of course, when we're dealing with these patients, you've got to be very meticulous, and I'll come to that later. And post-op, what's very important, and this is an area in thoracic surgery that we know will improve the outcomes in patients, is very good adequate control. A lot of patients basically say that, oh, it's painful, but I can, don't need to take pain medicine. And this is the point where I always say that it doesn't matter if it's painful or not. You need to go on a regular analgesic level. This will help with your breathing and the pain post-op, and the outcomes are much better. You can always take it off at a later date where they're much better. So in my setup, basically, before I see, or when I see a patient in clinic, and when we're planning lung resection, I ensure that the CT scans that I see are not more than 3 months old. If they're older than that, then we will get a new CT scan for them, because things can change inside. Tumors can grow, and that will really, you have good pre-operative planning is very important with a CT scan. When they come to see me and I talk to them about any lung resection, I generally go through a standardized approach with everybody. I always tell them there's always risk of bleeding. We generally do about 80% of our work by VATS, but that doesn't mean that 80% is, there's also a conversion rate, and I think about 20% of that group tend to be converted. And I always tell them there's always a risk of bleeding or severe adhesions in there, and there's always risk of open thoracotomy. There's always risk of infection, pneumonia, wound infection. They can get postoperative empyema. Air leaks are very common with them, and you must tell them that you must expect there is some risk of air leak and prolonged air leak. Post-op pain, they can get chronic pain, and of course, risk of reoperation for any of the 3 main points above. On 1 week before surgery, usually I'll send them to do a complete blood test and see the patient who is seen by the anesthetist in the anesthesia clinic. They get a chest X-ray and ECG. They do their lung function test again one more time if it's not done already. And generally, for most patients above 50 years old who are smokers, I generally do a standardized cardiac assessment for them. I get an echo, and I usually do a dobutamine stress test or perfusion stress test for them, because you can actually pick up some sort of heart disease, and you don't want to be caught up post-operatively of them having an MI or intraoperatively having an MI. So it's important to get them to be worked up. So on the day of the operation, usually we fast them for 6 hours before the surgery, and we used to, I think a few years ago, we used to admit them a day before just to monitor, but we found out that's not optimum. So we just admit them on the day of the surgery in the morning, and then they go in for the surgery. So post-operative, they come out. All my patients generally go on, I don't put them on suction. I use the medulla, the Thorax system. And all the patients basically, -8 is like what we call a gravity mode, and we put them all on gravity mode, whatever, whether they do a lobe or whether they do a normal wedge or a segment. Unless they had significant bleeding intraop or they went for a decortication surgery, then we put them on some suction on day 1, and then on day 2, we put it back down to gravity mode. After the surgery, they go to the recovery bay, they get a chest X-ray, and then they go either back to the ward, or if we're not very sure, they're not doing too well, we send them to the high dependency. The next morning, basically, we put them on a soft diet, sit them on the bed, we ambulate them, get them to do a chest physio. And also along with that, we do the pre-op, the post-op day 1 chest X-ray and bloods. So now with the drain management, basically, if the drains have no air leak, if the output is under 300 mils from time of op until the next morning when we review them, the color is light hemoserous or even serous, and they ambulate and the chest X-ray look good and it's fine, we should just take the chest tube out. And we repeat an X-ray 4 hours later. If it's okay, we can discharge them. These are for all the simple wedge resections and stuff. And if those, we follow the same routine, but if we do a lobectomy or segmentectomy, we will actually just keep them in for 1 more day just to observe them, get them to ambulate, make sure they're okay with the physiotherapist. And we do a chest X-ray on post-op day 2, and if they're all right, we send them home. So coming down now, so that's what we do basically, and that's what we have done to mitigate any post-op complications and handle them accordingly then. So if any of those things are not good post-operatively, we'll come to managing them. So what are the most common things we have to deal with in the morbidity basically, or the complications? Generally, most of the time we can categorize into 3 main groups. Either it's a technical thing, usually bleeding, or the staple line opened up, or it didn't suture the lung properly whenever it's leaking. They can get pulmonary complications like pulmonary embolism, or they can even get a pneumonia, and of course cardiovascular in nature. Now, as you can see here, I think these are the list over here: bronchopleural and bleeding causes and miscellaneous causes, and there are many causes. And literally, if you were to talk on each one of this, again, like I mentioned, you can probably talk 30 slides on each of it. But I'm actually going to mainly focus on the bleeding aspect and the air leak aspect. But before we go to that, one thing very important is that we need to actually talk to patients and let them know about mortality. Whatever we do, there is always a risk of mortality. The risks are low, and I always tell my patients, like, even if you get into a car and you drive, there's always risk that something can happen, and an accident can happen, and you may not make it through your journey. So even then, with any surgery we do, especially lung surgery, I always tell them there's always a risk of mortality, but the mortality risk is low. And if they were to have a mortality risk, most of the time, if you deal with intraoperative, is really severe bleeding from the PA tear. But post-op journey, most of the time, they're either cardiovascular and pulmonary in nature. But these risks of mortality for our lung surgery patients really have really decreased over these years. And again, like I mentioned in my previous slides, it's really improvement because of our pre-operative selection. We really do a proper workup of these patients, and we select patients very well. We have very meticulous intraoperative techniques right now. And of course, we have improved our post-operative care significantly. Now, if you look at studies from 1961 all the way down to 2004, so about 40 years, 45 years plus, and if you look at lobectomy and pneumonectomy over here, you can see that the risk of mortality back then was very high, about 10%. And over time, it's really come down to a lot. And this is, again, because of the three factors I mentioned earlier. So from the BTS guideline 2010, they generally say that the risk of mortality on average, 30-day mortality for lobectomy is about 2.3% and about 5.8% for a pneumonectomy. So the pneumonectomy rates are definitely higher. We all know that. There are many causes for it, and I think that we all kind of know from any theory that right side pneumonectomies always have a higher risk than compared to the left side pneumonectomies. And if you're doing an extrapleural pneumonectomy, because this is a much more very difficult operation, the risk can go up to almost 11%. In 2007, published in Thorax, basically, they looked at 4,000 over patients. And you can see they looked at mortality for 30 days, and they looked at divided for women and men. They look at lobectomy and sublobar resection, bilobes, and pneumonectomies. And if you look at here, the under 70 years old group for females, literally under 1% here, and for males are probably under 2%. And of course, if you do a bilobectomy, the numbers for females increase by up to 4%, and for males go up to about 6.9% for under 70 years old. And if you look at if they're older, the number kind of almost doubles, almost triples, isn't it, over here in sense of percentage of death, of dying from the surgery. And we can definitely attribute this to probably the older people have many other comorbids along with it. Of course, if you're doing pneumonectomy, it's a much larger surgery, and definitely without a doubt, probably the tumor is more aggressive. You're doing a pneumonectomy for them, or the disease in the lung is much more worse. So there are many other factors that go along with it. But the risk also can be as high as 17% in the elderly female, and almost up 21% in the elderly male. In the US, they then looked at things like if you do, people are all going and doing VATS nowadays. Everyone's just doing a lot of VATS surgery. So they wanted to actually look like, okay, if you do a VATS surgery versus the thoracotomy for lobectomies, is there actually a change, or is there a decrease or an increase in the mortality rate? So this is published in 2017 in the Annals of American Thoracic Society. They looked at patients from 2009 to 2012, and over 27,000 patients underwent lobectomy in the United States. And, even up to 2017 in the US, you can see the numbers, 35% only actually had VATS surgery, and most of them actually had thoracotomies. And then they matched them, 9,000 were matched. And clearly in the match pair group, you can see that the mortality risk of people undergoing VATS lobectomies were much less, almost half than that of if you do the thoracotomy. We all know they have shorter length of stay, and basically even the complications of doing a VATS surgery was much lower than that when they do a thoracotomy. So what are the main things I'm going to talk about in this talk actually is I'm going to focus on bleeding, on air leaks, persistent space first, followed by air leaks, and then empyema I didn't want to go into because that's a really broad topic and we talk about BPF and stuff, so I left that out. But if you look at the major complications, like I mentioned to you earlier, and what I always counsel my patients is, we always talk about bleeding, addicts, and empyema. These are the most common things we deal with. So postoperative bleeding now, literally, actually, post-op bleeding in for lung resections is actually very, very uncommon. And what's the actual number? For thoracotomies, it's actually 0.1 to about 3% of these patients, and under 2% for VATS surgery. And even then, in this group, if you need to re-explore them, they're actually only under 2% of any pulmonary resection that we do if they're thoracotomy, and literally only 1% if we do it by VATS. And what's the most common thing that causes actually, Jenny? Patients who undergo surgery, from the data out there, says that almost 25 of them are taking some sort of medically prescribed anticoagulation, either aspirin, Plavix, or they're on warfarin or some sort of blood thinner. And this really can contribute to the post-operative bleeding. Another big thing actually, and for me this is very common, and we've learned it the hard way, especially when we're doing cardiac, when I used to do cardiac back in the days, that a lot of people take herbal medicine. And in America, 40% of them take herbal medicine, and about 50%, pretty sure about more than 50% of the Asian population take herbal medicine. And the herbal medicine may not just be tablets. A lot of them come in like herbal soup, or very famous bakute soup, or herbal soup, or some sort of thing, bird's nest that they take. And very commonly also nowadays you can see ginkgo. I'm sure this is everywhere right now. Ginkgo is for weight loss and things. And if you look at some of the herbs, ginkgo biloba, ginseng, saw palmetto, the people take this for liver, and all these things actually can cause platelet dysfunction. And you're sometimes wondering, you don't talk to your patients, you don't tell them, stop this. They think it's normal and it's natural, they take it. And when you're doing the surgery, you notice, wow, why is this guy so oozy? And then when you go back and take a history again, you find out, oh my gosh, they've been taking these herbal medications. So you need to always check them. So I always ask this question: if you're taking any herbal meds or taking any sort of supplement, or even in their food, like soups or that they eat, I always say stop all this for at least 2 weeks. If they are taking warfarin, I usually stop the warfarin for 5 days. I check their INR, and if the INR exceeds more than 1.5, I generally get some FFP standby. If it's very high, 2.0 or something, I don't proceed for surgery. I wait it out until it comes down to under 1.5. Those who are taking aspirin and Plavix, if we can discontinue it, we tell them to stop it completely for at least 7 days. And but some patients who have stents, and those who have stents under a year, generally I will talk to my cardiologist, and usually I will operate with these patients with just aspirin but not with Plavix. There are a lot of stents nowadays that actually only need DAPT for 6 weeks, and then you can change it over just to aspirin, and then I think you can actually perform operations safely. Just be a bit more meticulous, and you can actually do the surgery with aspirin on board. Of course, chemo, we know chemo and RT has always high risk of bleeding, and the re-exploratory rates from the data is about 0.7 up to about 1.5%. So, what do we do? So say you've done the VATS lobectomy or thoracotomy, and the patient goes back to the high D or is in the ward, and then suddenly you see like 1 liter of fluid comes out in 1 hour. Really, you shouldn't sit and wait. I think you should just take the patient back and explore, because having a 1 liter bleed straight away is something very catastrophic for the patient's hemodynamics. And then if you observe this patient and they're having bleeds 200 mils every hour for about 2 to 4 hours, you should also go back and take a look at this patient. And of course, if you suddenly see a sudden output of 400 mils of fresh blood coming out, go back and take a look. And of course, if you get an x-ray like this post-op, I don't think there's anything to correct anymore. You should just always go back and re-explore the patient and see what to do. So when you're going to take the patient back, I think always anticipate the worst. I mean, the odds of a pulmonary artery opening up is very, very rare with staplers. But notice some people use silk ties or clips, and these can slip and they can cause a lot of bad bleeding. So you always anticipate the worst. Get 4 to 6 units of packed cells. I think the rest are mainly for like if you have some derangement in the blood levels, you should get all the platelets, FFP, and cryo ready if you feel any of the other levels are deranged. So intraoperative approach, when you go back in, generally, if from history, if they actually have bleed, the risk of death is almost up to about 10%, but I think these levels are much lower now. And generally, most of the bleeding areas can come from, just give me a minute, sorry. Sorry. Hold on, my Siri is being activated. Just give me a minute. Sorry for that. Okay, yeah, where were we? Yeah, so bleeding basically can come from mainly like mediastinal or bronchial vessels, and those can bleed, so about 23% of them. Intercostal vessels, now if you do a thoracotomy and you don't secure the intercostal vessels well, they actually can bleed from over there. My previous bosses always used to teach me and said, oh, you need to put a tie around the rib and secure it tight, or make sure you catch the intercostal and tight. But I've actually stopped doing that, and I actually really just use a diathermy to burn it thoroughly if I feel it's bleeding. And so far that's worked, but I think you must be very meticulous here. Bleeding from pulmonary vessels can be very catastrophic. That accounts about 17% right now. And of course, no specific side of bleeding. You have, this is very, very common. You go in there, you check everything, and you find out that the bleeding has stopped, and that's about 41% of them. So again, evaluate properly, check the intercostals, check the bronchial vessels, check the lung parenchyma, and then look at the lymphatic beds. And lymphatic beds, or when you do especially extensive dissection, they can actually ooze, especially if you're just doing it with a hook diathermy. I think the risk of it bleeding with harmonic or a ligature is probably less. But I don't have the evidence behind that, but I'm pretty sure it has a probably better sealant level. We know if it's coming from the pulmonary vessels, again, I say it's very catastrophic. And you need to check all the staple line, check everything. If it's bleeding on the staple line, you can always put an extra clip there, or you can even put a stitch on it. So when you actually need to re-explore sometimes, and if you feel the patient's sort of stable, you can actually go back in through a VATS way, and I think many surgeons are doing that now. But if you feel the patient's really unstable, then I think you need to go in and do a thoracotomy. So I don't have videos of post-op bleeding for me going in there, but I want to show you that these are the things that you can encounter intra-op. And this is from a hook diathermy, what we're trying to, while we're trying to hook the fascia off the artery, we end up burning the branch of the truncus. And you can see, so we need to get around it. You see, it's actively. This is very, actually, on the scope, on the VAT scope, it looks like, oh my God, it's really big, but it's actually a very, very, very small hole. And so once you go around the vessel, you can actually still put a sucker there to compress it temporarily. And for this particular case, I could actually just pass the stapler through and staple it. But what happened was after we stapled it, you can see right now, after we stapled it, it still continued to have a small spurt there, and you can just use a clip to just stop the bleeding straight away. And I think that does its good job very well. And here we go. You can see that thing is still spurting away. And so you can just put a clip, and then once you put the clip in there, you can just continue with your lobectomy. Right, and this is another one doing a lobectomy. And if you, what I'm trying to relate to is that these are what things you do intra, but if you come back in and you have a ooze from the PA, you can see it's very small ooze initially, but I'll just jump a little bit. You just put some pressure. And I always tell people, when you have a pulmonary artery bleed, there's always 4 things you need to do. The first thing you need to do is put pressure, get your poise, be patient, and the last one is the 4th P is always pray. But I think the praying part you do while you're pressing. So here's one thing where we're just compressing it, and after compressing it, it's still oozing away. And again, we can see this purely because of just a hook diathermy or a burn to the pulmonary artery. It's a very small bleed, and you can control it. So what we did was we put a Tachoseal, and I want to just show you how sometimes tachoseals are, they crumble so easily and it's so difficult, and you can see it's all over the shop. So once you get it right and you put it in there and you hold it steadily, you then get a wet gauze and you put it over and compress it. And literally you need to just compress it over a few minutes. And eventually, I just showed the longer video of how long we were compressing it for, but eventually it will look something like this when you take it out. So tachoseals are good to, if like post-operatively, if any ooze or something, you can actually put a tachoseal over it. But the best thing to do is always either a clip or a stitch if it's small. So I'm coming to my case presentations of bleedings that I've encountered, from very simple bleeds to some difficult cases, and I wanted to show you guys what I've encountered. So this is a young male with a spontaneous pneumothorax and had a second episode of a pneumothorax, so that's an indication for surgery. So we did a bulectomy for him, did a VATS bulectomy, and we did a pleurectomy where we peeled the parietal pleural layer off, and we hope that will then create bridging fibrosis between the lung and the chest wall. So you can see post-op, actually everything looked good, but retrospectively looking back, there's a bit more haziness and shadowing here, but we thought, okay, it's fine. The issue with him is that he didn't have any catastrophic bleed, and he was actually hemodynamically very well. HB didn't drop very much at all, but he always had this very, very dark, bloody output, and it was about 100 ml a day on post-op day 2. Post-op day 3 was still about 100 ml a day, but you can see the x-ray is getting worse and worse right now. So over here you get more hematoma formation, and you can see the haziness of the lung is gradually getting more, so which kind of lets me know that there's probably some blood collecting posteriorly. And so he had to earn his surgery, and this is very clear. This is on the day of the op 13.2, and then till post-op day 4, he dropped 3 points in total. So we took him back, we did a VATS, we evacuated the hematoma, and again, no actual bleeding site at all. So what I'm trying to tell, this is the final x-ray a few weeks later. What I'm trying to say is that even though the ooze is very little and maybe just 100 mils a day, I think it's important that maybe you don't need to take him back. Maybe these things will stop by themselves. But if they continue to persist and you see a constant hemoglobin drop, then I think that is definitely an indication to go back in. This is one of my most difficult cases I actually did, or most difficult complications I had to deal with post-operatively. And a lot of the case studies that I'm going to show you is actually what happened to me in my first 2 years of practice. Of course, I still get complications, but I've learned from these, and I'll point out to you a few mistakes I've done along the way. So case 2 is, I always call it the case of a recurrent whiteout lung. So we had a 69-year-old male, diabetic, hypertensive. He was a smoker, and he had a big right upper lobe mass, and was involving the second and third rib, and also the right middle lobe. Had a CT guided biopsy, was an adeno-CA, had a PET scan, everything looked fine except for the mass. And we put him through an EBUS, they biopsied the lymph nodes, and they were all negative. FEV1 was 70%, DLCO was not very good at 51%, but we felt that we could put him through a tumor board, and we could go for a curative lung resection for him. So we did a right thoracotomy. We resected the second and third ribs and the right upper and middle lobe, took out the lymph nodes, and of course, I'm even asking myself this question of why I reconstructed the third rib. The sixth rib we actually fractured when we retracted the rib, so we thought, okay, we'll fix it since we open up the set. So here we go. Okay, so what we did, this is the intraop findings. We fractured the sixth rib, so we stabilized the matrix rib. And again, I will question myself today on why you need to fix the third rib, because I've spoken about chest wall reconstruction, and you don't need to actually fix the third rib if you're just resecting that. So this is the post-op x-ray. And he did really well. He went back to the Heidi the next morning. This is his post-op day 1 x-ray. He had his breakfast, and the ICU team was so confident they sent him up to the general ward in the evening. But when I went to see him in the morning the next day, he was very tachypnic, and he didn't look too well. And we did his bloods, and this is the x-ray. You can see here there's a lot of opacities within the resected lung, the hemithorax of the resected lung. But one thing was not clear was that there was no actual drop in HP. And the output of the drain was very minimal, and it wasn't even the bloody kind of drain. So we said, look, let's drop him down to the ICU and let's get a CT scan to see what's going on here. So if you look at the CT scan, the whole lower, he's only got lower lobe left. Think about maybe 90% of the lower lobe is completely collapsed, and there's very little effusion. And the scans higher above show the bloody a mucus obstruction in the right lower lobe. So we intubated him because he was a bit restless, and we did a bronchoscope and we sucked out all the mucus, and we also found bits of rice in there, so he probably aspirated a little bit too. And we after aspirating all the secretions from the airway, the lung re-expanded and it looked okay. So he remained in high D. We extubated him the next day, post-op day 3, but he got re-intubated again day 4 for acidosis. And then we extubated him on day 6. And throughout this time, the X-ray was looking very, very fine. So on post-op day 7, we go to see him and wide out again. And this time I'm going, okay, don't tell me it's a collapsed lung again. But what's significant is, look at this. The HP has dropped now from 10 to 7. And this again tells us something very, very clear, that there is definitely a bleed going on here. So we got a CT scan for him again, and you can see it's a huge hematoma over here in the right hemithorax. So we went in, did a rethoracotomy. We evacuated the hemothorax, hemostased, and we did a chest washout. And intraop, we had 500 mils of blood clots, no obvious bleeding sites. There were some raw surfaces. But other than that, the PA, the stumps were all intact. And we just washed up thoroughly, and then we put some Tachoseal over the raw surfaces and came out. So post-op, again, not the best X-ray, but we thought, okay, look, this is the best we can do, and let's wait it out. So this is second day from the second surgery, and 10 day from the first surgery, and this is what the X-ray looked like. He was stable. We took out the other chest drain. We kept one chest draining just for observation. And we sent him up to the ward on day 4 of the second operation. And guess what happened on day 4? Wide out again. So really, it can't happen 3 times in a row. So we did a HB check again, and the HB was stable. And this time, I said, gotta be mucus plugging in. I didn't want to put him through another CT scan. So got the physiotherapist in, napped him, and really patted his back out. And right after the physio, the lung re-expanded back up again. So, surprisingly, when we took out the tube, got him to walk around, and we discharged him, this is what the X-ray looked like when we discharged him. So a case of recurrent wide-out lung is one of the most difficult things I had to deal with in my junior time of being a consultant. Again, I question myself on this matrix trip here, but you learn from that. So that's about the bleedings that we deal with, and my post-operative bleedings how we deal with. The next area I want to talk about is that what we, as surgeons, thoracic surgeons, we always have encountered is post-lobectomy spaces. And really, post-lobectomy spaces can be many causes behind it, but mainly you have to deal with physiological airspace, air leaks, and subacute emphysema, and of course, one of the other causes is the reduced lung compliance. And that's why the lung doesn't fill the space thoroughly. So again, residual space can always be an underestimated complication, but most of the time, generally these persistent spaces are not actually really functionally detrimental to them. And generally always just a disturbing radiological finding for us surgeons. And very important is treat the patient and not treat the x-rays. Where I send this message to my juniors because they said, oh, there's a pneumothorax, up the suction, then they down the suction, and they up the suction, and down the suction, and you're not doing any justice to yourself or to the patient by doing this. So don't treat the x-ray, treat the patient. So physiological residual space is actually very, very common. When you remove a lobe, you're taking up, if it's an upper lobe, almost about 30% of that particular lung. If you're doing a bilobe, you're taking up 50% of that lung. And so it takes time for the lung to actually really, really expand and fill up that space. So if you get your chest tube in a good position and it's not blocked or it's not sitting in the fissure, eventually with time, as the lung expands, the diaphragm moves up, the mediastinum shifts a little bit, the space will fill up. So don't worry about that. But, and this is an example here, after lobectomy, you got a physical air space over here. And I never worry about it. My chest tubes are still on gravity mode. And if there's no air leak, we pull the tube out. And literally after a day or two, the lung just re-expands again. So don't worry about it. And the issue you have to worry right now is air leaks. Now, Dr. Khan, I think, had a beautiful presentation on PALs. And I went through and saw what he spoke about. So I don't want to touch on the theory aspect of it, but more on the clinical aspect of things. So we know that most of these air leaks are alveolar air leaks, and they're very different from BPFs. And I completely agree with Dr. Khan always says, an alveolar leak is not a BPF. Every time someone tells me it's a BPF, it's like a 4-letter word for me, or 3-letter word for me. I'm like, it's not a BPF, it's an alveolar leak, so don't confuse those two. And it's very important for us to actually educate our respiratory physicians whenever they say that, because when we say BPF, that's a whole different ballgame. I'm not going to go into that. I'm going to talk more on what we deal with generally most of the time. So in the initial phase, it's always difficult to know whether, well, you sort of know if it's a small leak, you know it's coming from the alveolar. But sometimes when we like do decortications and stuff, and there's a lot of tears and you repair as much, but because there's still a lot of big leaks, post-op you can have leaks up to about 2,000 mils. But you know for certain this is not a BPF, and they generally tend to come down very quickly after that. So what defines actually a long air leak is actually, STS defines as more than 5 days. And I always wondered, why actually was it 5 days as a resident? Why is it 5 days? Where you get a number? So actually, really, they define it as more than 5 days because it exceeds the average stay of a normal lobectomy patient. That's what prolonged air leak actually is, and why they got that number 5 days. And if you get an air leak, of course, we know the patient stays longer, and they have a lot of complications that can come with it, and it's associated with higher risk of morbidity, atelectasis, pneumonia, and of course, infection, empyema. All right, but please understand one thing, and most air leaks always generally, about 95% of them stop within 2 to 3 weeks, even the worst ones, if it's an alveolar air leak. All right, so again, risk factors, again, I think Dr. Khan went through it, so I'm just gonna mention it out. But what is important over here is that when you do the surgery, it's very, very important to free up every adhesion from the lung, from the chest wall. This allows the lung to actually get mobilized. A lot of times, I've seen 1 or 2 people have done is that they don't free up completely because they said, oh, too much work and I have to free it off the diaphragm. But actually, you're not going to allow, the lung then can't fill up the space if you don't free up this adhesion. So you must free up the adhesions, thoroughly, completely mobilize it off the pericardium, off the chest wall, off the diaphragm. That's very, very important. Of course, there's high risk. You do upper and bilobectomies because, again, the lower lobe takes time to fill up and go to the top and reach the apex of the lung. So it is definitely longer. And of course, one big issue is that if you have an air leak and the lung is expanded, okay, you know it's going to probably seal. But if you have a continuously collapsed lung and it's an ongoing air leak, this is a risk factor and something that you need to take more notice of, and these are probably one of the main causes of it. You're going to probably know that it's going to be a longer duration of stay for the patient, or the longer duration of chest tube. So this paper was published in ATS, by Dr. Sunil Singhal, and he looked at the number of patients who actually had pulmonary resections, and so he reported that most of these patients, 28 to about 60% of these patients actually have postoperative air leaks. And so on the post-op day 1, right after surgery, maybe you can get up to 60%, but on post-op day 1, this number tends to come down. And on day 2, you can see it's almost down to about 25%. Most of them, again, by day 4, they generally tend to seal off. And this is from his observational study that he did. Sorry. Okay, yes. So again, back to, like I mentioned to you, you know, if you want to avoid these leaks and you want to get the lung to heal faster, is that you got to free up all the adhesions, mobilize the lung. If the lung has some empyema on it, when you're doing it, especially for infected cases, decorticate the lung, make sure the lung can actually expand, free up the inferior pulmonary ligament. You can do something called pleural tenting. I'll show you a video of a pleural tenting afterwards. You can use surgical sealants, Neovil, but I'll show you another video after this that shows that these may not be the best options. There's one of complication that I encountered. Buttress sutures, and of course you can use muscle flaps, which we'll talk about later. So you've come back to the, after you've done the resection, you've come back now to the ward, and you see there's bubbles in the chest bottle. So what to do next? So Robert's folio, again, Dr. Khan spoke about this, but Robert's folio's classification on air leaks, grade 1, 3. But one thing I wanted to bring forward was something I discovered was Dr. Takamochi in 2017 presented his data on, and he graded the type of air leaks according to the digital suction graphs. And I think most of us are actually using these digital suction graphs, and it's a really great benefit to us on how we actually we can actually plan ahead and know whether these patients actually are going to get prolonged air leak or not. So he graded into 5 grades, type A to E. And type A is, of course, normal, no air leak. You're pretty certain, and usually you can take the chest tube out the next day. Now, type B is gradually decreasing air leak, and these are generally showing a healing pattern in the lung. So you can see they have a big air leak first, and you can have a downward pattern. So this is a type B. A type C also is what we call intermittent, where they have no air leak and suddenly they get air leak and then no air leak again. And again, this is a healing pattern. So you know these are probably going to heal and settle down. But what you're going to have to worry is actually about the type D and type E leaks. And these are the things that you can probably gauge by day 2, day 3, really that this guy is probably going to have a prolonged air leak. And these are the ones that it's just, you know, it goes up and down, and doesn't resolve in a few days. And of course, I think the worst one is the type E, where it's stable and then it spikes up again. So this is definitely going to be a delayed healing. And this kind of sets your mindset of how you're going to manage the patient. So Dr. Takamochi's data basically shows that type B to type E, you can see that type E had probably the longest duration of air leak, and the chest tube, of course, was placed longer. One thing to look at also is the amount or the peak of the air leakages that he presented here. And if the peak goes up to about 400, even if it's 1 shot or 2 shots or 3 shots, you probably can expect longer air leaks and longer duration of chest tube placement. So it's a good paper to look at. And I think, you know, if anybody is keen, you know, this is a good paper to do prospectively study to just reaffirm his results. You know, I think this is something that we can look at. So you've got the patient back into the ward, and you notice there's bubbles there, or you see your graph and you see, okay, there's an air leak. And then you take an x-ray, there's a small space there, and you go, okay, what to do now? Shall I put on suction? Should I put on gravity mode? You know, what do I do? So when you put on suction, yes, you get the lung is going to expand. It's normal because you're creating a more negative pressure suction system. So the lung's going to pull open, and it's going to improve the chest x-ray. So you're going to improve the lung re-expansion. You're going to minimize the pleural defect, and we're going to feel a lot better internally. But I don't know whether it's going to help the patient a lot. And of course, if, like I mentioned, if you're doing a decot or you're doing a bleeding, you're going to put on suction. I think that is definitely warranted. So what about no suction? So no suction, basically, if you don't suck it, they always say that the leak won't be kept open. And so when that leak is not kept open, it can actually oppose together, and then it'll form adhesions with itself. It'll seal off, and then the lung can re-expand again. So I'm a fan of no suction after any lung surgery. And so I looked back at the data and wanted to see if I'm actually doing the right thing or not. And really the experience actually comes from the lung volume reduction experience. And they are the ones who started questioning whether we should actually use suction or no suction. So this paper by Cooper, published in a Journal of Thoracic and Cardiovascular Surgery in 1996, he had about 150 patients who underwent bilateral LVRS surgery for severe emphysema. And generally, in his conclusion, he avoided suction for most of his patients. And he only applied suction if his post-op X-ray showed more than 30% pneumothorax, or the underlying lung appeared restricted or compressed and could not expand thoroughly because of maybe very, very bad flow compliance, or there was very bad subacute emphysema. And again, in one of his statements in his discussion, he said that only 10 out of the last 50 patients actually required any sort of suctioning postoperatively. And if they actually still had an air leak after that, he just put them on a Heimlich valve and he discharged them. In thoracic clinics, on complications, one of the complication topic, they looked at a few of the randomized control studies that were done. And so you can see like NES means no external suction. So out of 1, 2, 3, 4, 5, 6, you can see that 1, 2, 3, 4 said benefits of no suction. And they commented that there were better sealing. But there were some studies that said better to put suction. So really, I came down and said, okay, so let's look at the real hard evidence. Let's go down to the meta-analysis and see. So ICTVS 2018, they looked at 10 RCTs at 1,600 over patients. And they looked at it. So this is with suction, this is no suction group. Again, most of them were not statistically significant. You can see the confidence intervals are crossing 1 over here. But they kind of favored non-suction. So prolonged air leak means those who, it was more for the suction group that had prolonged air leak versus the non-suction group that had less prolonged air leak. Of course, post-op pneumothorax, this is self-explanatory, isn't it? You put on suction, the lung fills up. So this was significant with suction. And the duration of chest tube and duration of air leak, again, the duration of chest tube was more favoring. That means lesser duration on non-suction and lesser duration on air leak. But again, they were all non-significant if you look at the confidence intervals. All right. And the last one was the length of hospital stay. Again, non-significant, but they were favoring more on the non-suction group where they said that they had a lesser stay. So at the end of the day, the cartoon over here says that, you know, suction resulted in lower occurrence of postoperative pneumothorax, but longer chest tube duration and same length of hospital stay. So really, the jury's still out, so what to do? But you know, their take-home message was that suction may be as effective as simple water drainage for postoperative chest range following pulmonary surgery. So again, something to think about. So I always say, what to do lah? You know, it's a Singapore or Malaysian slang, they always say lah. And so in my practice, basically, I don't use any suction, like I said, unless, again, you have a big or symptomatic or growing pneumothorax, you're getting a lot of subacute emphysema, patient has a clinical deterioration, or patients who go for have a DCOT, or patients who actually have hemothorax or a lot of bloody secretion, then I want to suck it all up. So for patients that now they're in the ward, they're still having an air leak, and for me, it's 7 days. My mark is 7 days. What I do is I put them on the Heimlich valve. And I've got, I think maybe about more than 20, 30 patients in this past maybe 3 years or two years that actually have gone back on the Heimlich valve. And I'm very happy with this valve. I've never had any issues at all with it. This is the blow-off valve over here. And you can, when the patient coughs, you can see the valve will open up. And so who do I put on? Basically, if they are small pneumothoraxes, they're stable, there's still an air leak, and I'll put them on. But before that, what we do is we check and see whether is this just a space that's there, or is it actually really a pneumothorax? So if you have the digital drainage that just tells you don't have to do this, but if you're really not sure, and the digital drainage system or the Mandela always tells us anything under 20 you can take out the tube, but I completely disagree with them because I've pulled out drains under 20 and the pneumothorax is re-occurred literally within 24 hours. So actually for me, I really need a 0 number to go with it. So if it's in that group where 10, 20, 10, 20, I'm not sure, I do the chest tube clamping method. So what I do is I do an x-ray in the morning, first thing in the morning, I clamp the tube. So I do an x-ray first thing in the morning, then I clamp the tube for 6 hours. So x-ray is usually done by 7:38. We will review them at 8:30, we clamp the tube, and then we do an x-ray at 2:30 p.m. If the repeat x-ray looks good and it's fine, we'll take out the tube. But we will take out the tube. But if the x-ray doesn't look good, then we just send them home with the Heimlich valve. But if you're saying you've clamped the tube and the x-ray maybe slightly more increased pneumothorax, you're not sure and you use you don't want to send him back with a Heimlich valve yet, I will usually keep the tube clamped overnight. The reason is that he's been clamped for 6 hours in the morning and in the afternoon and up to the evening. If he doesn't show any signs of deterioration, I'm pretty sure I can clamp it overnight. So I usually keep the clamp overnight and repeat an x-ray in the morning. And if it's stable, I take out the tube. If not, they go home on the Heimlich valve. But always do this first thing in the morning. I tell every of my residents, because we get a very long duration to monitor them. So if there are any signs of increasing pneumothorax or clinical deterioration, then we can pick it up and unclamp the tube early. So when I send them back on the Heimlich valve, what do? I get them to see me back in the clinic a week later. Again, I get them to be always put on the first patient of the clinic day. So they come at 8 o'clock in the morning, they'll get registered, and then they'll go and get a chest x-ray done. And I'll come to the clinic by 9 o'clock. I'll ask them to do the cough test. And if there's no cough, I will then, no cough impulse on the Heimlich valve, I will clamp the tube. Again, clamp the tube for 6 hours, ask them to hang around in the clinic, and then I do an x-ray 6 hours later. If it's okay, I take out the tube. And so then I will get them to see me back again the following week and do another x-ray. But if they have still an ongoing air leak, I'll just say, okay, go home, come back next week, and we'll do the same thing as I mentioned earlier. The longest patient I've actually ever had on a Heimlich valve was 21 days. And he was fine, got used to it. So again, Robert Cifolio had, he looked at his group of patients. He had a huge group, 199 patients, discharged home on the Heimlich valve. And he said literally he could remove most of the tubes within a week. But 9 of his patients actually had a persistent leak even after 2 weeks of management. But he said that, and when I even spoke to him, he said, it's okay, he clamped the tube and he took it out. Even if there was a slightly bigger pneumothorax, he just took the tube out and he was comfortable with it and the patients were well. So it's something that I don't dare to do, but this is the evidence out there. So if you want to try that, there is at least some evidence behind it. So now, another thing is that, which we deal with is that if there is still a prolonged air leak and you don't want to send the patient home on a Heimlich valve, or you don't have that kind of thing, is that what you can do is if the lung has expanded and there's a leak still there, you can then inject talc or tetracycline or even blood through the chest tube, and that will act like a pleurodesist for the patient. And I think there are many reports out there that says it's pretty effective and it actually reduces the duration of leak. Dr. Khan spoke about endobronchial valves and surgical intervention. After that, I have no experience using endobronchial valves, so I can't comment much on that. But for surgical intervention, when to go in is actually something that you have to decide on a case-by-case basis. Like I mentioned, 92% of them, stop within a week, and only 8% will go back on the Heimlich valve. And even those group of Heimlich valves, you can actually take out the tube after 2 to 3 weeks, they stop. But having said that, I've had patients where I had to go back in and here are my case presentations for prolonged air leak. So this is a lady who had a GGO in the posterior segment of the upper lobe on the right side. So we went in and we wedged it. We sent it for frozen section. It came out as a adeno, and we decided to do a lobectomy for the patient. So this is the pre-CT scan and this is the post-op X-ray. And post-op, she had some air leak, and I'll show you the video on why I should have done something else. But anyway, I'll talk about it after this. So post-op X-ray look okay. Lung sort of there's a space there. She had an air leak. I thought it was fine, but her air leak kind of persisted for some time, and she wanted to stay in the ward, so we kept her in the ward. And so after 2 weeks, we did the clamping test, and it looked good. She had a space, but we clamped it for I kept it clamped for 48 hours instead for her. And it sort of was stable, so I thought, okay, this is a persistent space, let's just take out the tube. So we took out the tube and discharged her. And she came back to the clinic, came back to the clinic a few times, but I just want to show you the 6 weeks post-op X-ray, showed the lung kind of coming up again. And we were very happy. We said, okay, great, we'll see you back in 3 months. But 3 months later, when she comes back, look at this, the lung is gone down. It's big pneumothorax over here, but surprisingly, she didn't have any hydro, or usually if there's a space, there'll be fluid buildup, isn't it? And then there by now the pleural probably would have healed, but maybe there'll be like subacute emphysema and stuff. And she was quite well, but one thing she always told me, she said, "Doctor, I always feel like I got a bubbling sound inside my chest." And I think it's very important for us as surgeons to not ignore these things, but listen to the patient. But the X-ray kind of speaks for himself. And you would think, oh, is there a BPF there? And the stump open up, but she didn't have all that pink frothy sputum and everything. So it was kind of weird. So I went back and said, look, you got to get admitted. So we admitted her. We put a chest tube in, did a CT scan. You can see the middle lobe's kind of okay. It's expanded. The lower lobe's kind of expanded. So what's going on here? So I looked back at my videos and we said, look, I'm going to take you back in and see what's going on. So, but before that, when we put the chest tube, there was an air leak, almost about 300-400 mils per minute. So we took her back for surgery, did a broncho intra-op, and then we did a VATS up there for her. We did adhesiolysis. We found there was a raw surface on the superior segment of the lung. We repaired with a Proline O. There was some middle lobe adhesions. We took it down and then we stapled that part of it. And the stumps were all intact. So here's the video of the pre-op. And I will tell you why many mistakes I can learn from this video. And we look back at this video and many of you also. This is the surgery, lobectomy done. You can see here, there is a raw space on the superior segment over here. And there was some bubbles. You can see some very mild bubbles. So we thought, there we go, right? And this is the raw surface over here. Okay, so now in my practice right now, I will stitch it. But at that time, I thought, this will resolve. We've seen people put stuff on it and it heal. So that's exactly what I did. I don't know whether I was just lazy or what, but so I put Tachoseal snow, patted that area there. And then I sprayed lots and lots of glue, lots and lots of glue. So now look at this photo over here with all this glue here. Now, I've learned this thing. Glue takes about 2 to 3 weeks for it to completely dissolve. And then the Tachoseal snow can be persistent for up to 3 months over there. Now, when we have air leaks, what happens is the air leak component will touch against any tissue around the lung, the chest wall, the mediastinum, and you'll form adhesions. And these adhesions will eventually seal up and seal the leak. But when you put this much of glue, when you put this much of glue over the raw surface over here, it takes 2 weeks for it to dissolve. It takes then another 3 months for the Tachoseal to dissolve. So that lung component over there really never actually healed. And then so there's no apposition of it. So we actually had a false reading because the snow and Tachoseal was padding seal the leak, but the lung actually never healed. So this is what happened when we took the patient back after that. So you see, then threw some more Tachoseal in there and really padded it all up and thinking, okay, so false sense of security for me that day. And so 3 months later when we went in, what did we see? So you can see here, all the glue is dissolved, but look at that. There's still some remnant Surgicel still there. All right. And what we did was we cleaned up all this old Surgicel that's on it. We swept it all off. Maybe there was still maybe some bits of glue, I don't know, 3 months there. And then we did the leak test, and here we go. That part of the lung, remember the raw surface that I showed you all, you can see here, it never healed actually. And imagine if I left it and it stuck to the mediastinum, maybe it would have sealed by itself, I don't know. But the best thing you should have done is I should have done this. It takes literally 3 to 5 minutes to stitch. And once you stitch it, I probably would have avoided all these problems from her. And so you can see after we stitch it up, there was no more leak. And yeah, so that's that. So this is the pre-op before we took her back the second time X-ray, and you can see post-op the lung has expanded quite nicely. Follow-up in clinic, there was some space within. Sorry, this thing's blocking here. Within 2 months post-repair, now there's a hydropneumothorax, but she was again very stable, and I was pretty sure I got it all. So I said, look, now we can just wait. You don't have to treat the space now. Wait it out. And this was the X-ray 5 to 6 months later. You can see the lung is expanded. We got a CT scan for her, and I literally all the views, there was no space anymore over there, and it kind of a lot of adhesions have probably formed over there. And this is 2 years post-op. You can see the lung. So once you know for sure you've got the leak, you've sealed it, and you've done all your testing. And what I wanted to show you is that post-op, maybe you still got a space there, but this time we were very, very certain that everything was probably, it's not going to recur again. So the second case I wanted to show you is, again, a VETS bulectomy for pneumothorax case, and we did a pleurectomy for this patient. And this patient actually had a constant leak every day. You know, it wasn't healing. It actually was that exactly the type E, like how we demonstrated, 100 to 500 mils a day, and he was just sitting in the ward, and the parents didn't want to put a Henry valve in, so we said, okay, let's take him back and let's see what happened. And here we go, you can see the pleura is all peeled off here, and there's a constant bubbling over here. And you can see that there's another ruptured bullae over here. And none of the pleurectomy that I did, so the whole lung the pleurectomy didn't even take, basically, that, or the lung didn't even take to the chest wall. So, and knowing very well that, you know, he's getting another small bullae rupturing again. So what we did do is, after we stapled off that leaking component over there, we then did a top pleurodesis for him. Okay, so then we just spray powder away. So once the powder is done, this is how it looks like after you put the powder in there. We put a chest tube and we come out, and post-op he was quite well. The third case, again, one of my most troubling cases I've ever had to deal with, and was so happy that the patient actually went home after many months in hospital. It's a case of aspergilloma with a BPF and dealing with these air leaks. So very, very difficult case. Upper lobe's completely destroyed by the aspergilloma here, and had constantly persistent hemoptysis, so we had to go in. And so we did a right thoracotomy and upper lobectomy. And again, he had mycetoma, dense adhesions throughout the chest wall. We had to resect the fourth and fifth rib to gain access into the hemithorax. Again, we freed up the lung completely, and we had to do some extrapleural dissection for that. The fissures were fused, large bronchial arteries, we divided with a stapler. Then we did the same thing, PAPV, divided by vascular stapler. Upper lobe bronchus divided by the endostapler, and then we put an intercostal muscle flap on top of the bronchus, thinking that, you know, we should resecure it. But here's a good thing, again, something I'm knocking myself for. Lola was decorticated then, and then chest wall defect reconstructed with a Prolene mesh. I don't know what in the world I was thinking, that in an infected space you go and put a Prolene mesh to cover that space. So, so this whole complication, I don't know whether it's blame the surgeon and very, very bad decision on my side, but it's something we have to deal with. So unfortunately for him is that nothing to do with the mesh now, but literally 7 days after surgery, he picks up a bad pneumonia, got to be intubated, he had to be prone, and very bad infection, and we were aggressively treating him, antibiotics, and then suddenly now Pseudomonas was growing from the chest tube drainage, and spoke to the ID physician, and even, there's a mesh in there, and that mesh is like, that's like Burger King for Pseudomonas, or McDonald's for Pseudomonas. So anyway, we got him, restabilized him, managed to treat him, got him off back up to the ward, and he's actually just sitting there with his chest tube there, that's just spilling out pus every day from the tube. So after he was very, very stable, we said, look, and then started to have an air leak. So started to have a big air leak on coughing, you can see just bubbles every time he talks and stuff. So I thought, okay, let's do a scope for him, what's going on. And then you can see here the upper lobe stump had opened up. Okay, this is the bronchus intermedius, this is the upper lobe stump. So it's completely opened up. And so we went in back in there. So the ID physician told me, look, we're never going to treat this if we don't take it out. And one of the most difficult operations I think I ever went through is to remove this mesh off the lung. And so when we went and got it out, put another flap on the BPF. And post-op, he had this big space over here, and he still had a persistent leak. But we said, look, why don't you go home? And we will come back. I spoke to my respiratory physician, and I said, look, if you put the scope in and look at it, the stump is only about 5 mm in diameter that had opened up. So we said, let's give this a go. I don't know whether it's luck or whether it healed by itself. So we used a bronchoscope, brought him in, and put histoacrylic glue into the stump space over here. And after 6 months, you can see the whole thing actually kind of sealed off by itself. So is it the glue that did the job, or maybe it's just the body just self-sealed? I think it's that, but I thought I just wanted to show you all that. One thing I want to teach you all from this complication is that never put a mesh in an infected space. I don't know what I was thinking, but when you have to deal with it, you need to go back and take it out. And then you need to and if you get a BPF, you need to go back in and repair. So we did that thing, we put an intercostal flap, another flap on it and stuff, muscle flap on it, but that didn't work. And so we used the glue. So eventually, after 6 months, we kept the chest tube there. There was no more pus coming out from it. We kept the chest tube there, hoping that the BPF will seal. And eventually it sealed off, and we pulled out the chest tube. And this is an X-ray 1 year after his surgery, and he was very, very well. And so just wanted to just show you again the hole, the BPF hole, and the glue we injected in. And then at 5 months is what it looked like. At 5.5 months, and at 6 months, that's what it looked like. So we finally sealed it off. So those are my cases on prolonged air leak and how I dealt with it surgically. The other last two topics I'm going to touch on is subcutaneous emphysema. And this is very, very common what we deal with. And it's not common, but it's a complication we always deal with as thoracic surgeons, and we will definitely encounter it sometime in our career. So what is subcutaneous emphysema? Basically is air traveling in the subcutaneous plane. Why does it go there? It's because it's a path of least resistance. And then and how does it get there? It's because when we enter into the chest, we have to cut the pleura, the parietal pleura. And so that disrupts the space between the muscle and the parietal pleura. So there's an exit area for air to go into the subcutaneous plane over there. So Robert Saforio defined it as a clinically symptomatic subcutaneous emphysema is defined as air under the skin, and it is perceptible by the clinician, the patient, a family member, or he has a change in voice. And why does it happen? Basically in lung resections, again, like I mentioned to you, we cut the pleura. And so most of the time, the air usually should come out through the chest tube. But if the chest tube is blocked, or the leak is so big that the tube actually cannot drain the air out fast enough, it will then to track under the subcutaneous plane. Okay, and of course, you get these other things called recalcitrant subcutaneous emphysema is when that part that is leaking forms adhesions with the broken part of the pleura. So it has a direct communication with the subacute plane. So it's actually not going to exit out from your chest tube. It's going to go straight into the subacute plane straight away. So no matter how many chest tubes you put inside, you're not going to drain it because it's formed its own fistula over there. So those are what we call recalcitrant subacute emphysema. So the normal stuff we see are like x-rays like this, and I'm usually not too concerned about, but you know, when you see something like this, or you do a CT scan, something like this is definitely very, very worrying for all of us, and how do we manage it? When I looked up again some papers, actually there's not much out there on any big papers talking about subacute emphysema, but this was published in the Indian Journal, I think in 2013. And one thing this group did from Iran is that they graded the subacute emphysema, but there's no other study that has done this, and I think it's something that you can work on if you want to look at it. But I think what is worrying we always see is the grade 4 and grade 5s that is troublesome. And so, you know, this is a common feature, right? This is really bad. When it comes to this level, even the surgeon tends to get a bit worried. And then when they get the change of voice and it becomes like they start helium and they start talking like that, you tend to need to do something. So this is if you go to YouTube and you type subacute emphysema surgical incision on skin, it's a very nice video on YouTube. And in the UK they did that, and you can see when they cut the skin and they ask the patient to breathe, you can actually, and they milk the skin, you can actually see bubbles coming out from the tube. But I have never done this, and I don't know whether this is still commonly practiced. I think it's very morbid to do, but you know, what are your options? Basically, is number one is you can observe the patient, but if it's coming to that level, you don't. You can increase the suction. Is what you can commonly do. The first thing you do. Number two is you put another chest tube inside, and if the lung is expanded fully, and you got a subacute emphysema building up, please get a CT scan, because then it's probably a loculated pneumothorax that you cannot tackle. I've had a patient, I tried to look for the x-ray, I can't find it, where the x-ray showed the lung was fully expanded, it looked good. But when we did a CT scan, he had a huge pneumothorax posteriorly, because when they're doing an x-ray in the ward, they're doing an AP. So anteriorly, it looks very well expanded, but actually posteriorly, there's a big pneumothorax building up over there. So I generally will get a CT scan for this patient, or you can do a lateral x-ray if you want. And of course, this incision, I put a question mark there because I'm not a fan of this. And of course, surgery. So again, Robert Sofolio, he tried, actually, surprisingly, he actually used the word single VATS incision in 1998. And he did this he had how many patients? 64 patients who had recalcitrant subacute emphysema. And what he showed is he went in early, within 7 days, and he made an incision above his thoracotomy incision, and he put a scope inside, and then he found whatever, he felt that the adhesions were directly connected to the subcutaneous, so like I mentioned to you, the alveolar subcutaneous fistula, and he just broke all the adhesions, that's it, and he put the chest tube inside. And in his report, he said 63 out of 64 of his patients, the subacute had resolved in 24 hours. I don't know whether it disappeared, but I think probably it didn't progress. But this is what his conclusion was. So, you know, that's one way you can do. So in my practice, for subacute emphysema, what we do is I get a chest x-ray to see if there's a pneumothorax. Check if the chest tube is blocked, and make sure I milk the chest tube. And if the pneumothorax is persistent, put one more drain in straight away. If there's no pneumothorax or the lung, it looks expanded on x-ray, I always get a CT thorax and I get another drain in and put it on suction. So the last thing I want to talk about is other causes of residual space. And again, we deal with this commonly in our practice. And most of the time is because of the compliance of the lung. And so the lung basically has lost this elastic recoil. And you see this all in the chronic emphysematous patients, where the lung can't really expand. And so you will get a persistent space over here. And, you know, the causes are age, TB, infection, fibrotic changes, or if you have a concomitant pleural infection over here. So this is an example of a patient who had a secondary pneumothorax and considered doing like an LVRS, a large buoy on top, we resected it. And you can see he had a big post-operative leak. And so we preempted by putting 2 chest tubes inside. And the lung, even this I think was even with suction, the lung didn't come out at all. But we just hung in there. We followed the basic guidelines. We stopped the suction. We made sure the subQ didn't build up. We sent him back on a hammock valve, and post-operative, after a few weeks later, this is what his X-ray looks like, and it was quite well. Another thing is you always get this, I'm sure, in India, that you definitely have a lot of mycetoma that you deal with. So I think for you, for you all, this is probably very common, and you'll always get after because of the poor lung compliance, or if you don't decorticate properly the lung, you're going to have this thing called a fixed pleural space or fixed pleural defect. And you know, I'm generally never too concerned with this. You see the CT scan. So the CT scan was ordered by one of my registrars, worrying that there's something happening there. But it's good to tell you that, look, it's fine. You know, there will be a space, and you've got to accept it that it's going to be a chronic space. The last part I'm going to go to is that if you are concerned of that space, what do you do? I know this is not part of the complications talk, but I thought just touch on it a little bit. The goal of any surgery basically is to eliminate pleural space in thoracic surgery. And you can do many things intraop to preemptive yourself. So the first thing you can do is something very easy to do is stenting of the parietal pleura. Of course, you need to decorticate the pleura. You can also use muscle flaps to put in there. Or one thing I've learned is this diaphragmatic elevation. So people used to crush the diaphragm, and I think that's very, very wrong because that causes permanent damage of it. But you can actually inject some lignocaine into that to cause temporary paralysis, and that pushes the diaphragm up, and it kind of opposes the whole lung to the chest wall. Give it some time, and then eventually the diaphragm will regain its space after 1 or 2 days. And that really reduces your postoperative leaks. And unfortunately, I actually have done only one case like that for secondary pneumothorax, and it worked brilliantly. So I wish I had that video, but I'll look for it, and next time I'll send it to you all. So pleural tenting basically is to bring the pleura down, and this facilitates the lung expansion. So basically you bring the pleura to the lung, so the lung doesn't have to come to the pleura. So an example of this is actually not a pleural tenting, but this is actually a pleurectomy. But the concept is similar. So when you open up, this is the pleura. This is through a Batts incision, and you can see here. So this is the pleura over here. Just jump it a bit. I usually use my finger just to manually dissect the pleura away from the endothoracic fascia first. Okay, so you can see that we've pushed the, sorry, my CV is going haywire again. Yeah, so here we go. So what I do is after I push that part down and I got some space over here, I will then inject lignocaine into that space. And this also helps to separate the pleura away from the endothoracic fascia, so it makes it easier to peel. So you do that a few times. And you can then take your ring forceps or anything you can do, and you can peel the pleura down. This is actually a pleurectomy video, but the concept is very, very similar. So same thing. You pull you're peeling the pleura down away from the endothoracic fascia. And eventually, what you want to do is you don't want to break the pleura, but even if it breaks a little bit, it's okay. Sorry. So even if it breaks a little bit, but the idea is, I see you want to bring it down towards the lung area like that. So you can see here, if I just press pause, okay, you see here, so most of the pleura has come down over here. So this is like a tenting you can actually do. And then this will actually help to bring the lung closer to the pleural space. So post-op X-ray kind of looks like this when you're done with it. And that's one way to actually reduce your risk of postoperative leaks. Decortication, I think, is quite standard. I won't go too much into it. Muscle flaps, again, I won't go too much into it. But you know, we can use intercostal flaps, but the best flaps are actually straightest anterior flaps or the lat dorsi flaps when you put it in. Now, if you're not very good at it and it's your first time doing it, get your plastic surgeon colleagues to come and give you a helping hand because they are very good. But very important is if you're going to do a thoracotomy, don't cut the muscle. And that's very dangerous, and then you lose the vascular supply to it. So that's very, very important. Dr. Rocco, has a very good article on a few of procedures he's done, and how he's done it and his outcomes. And you can see here, these are the scans of after the muscle flap was placed inside in the X-ray. Okay, so the lastly is like I told you about the elevation of the diaphragm. Again, I'm just going to jump through it. The idea is basically is that you want to just numb the phrenic nerve to get the diaphragm to elevate up, and that pushes the whole lung up. So I've actually used 1 to 2 mils of directly injecting around, not into the nerve, but around the nerve area and paralyze the nerve, and that causes it to go up. I will never ever recommend you to grab the nerve or crush the nerve, because that causes a permanent damage. So try to not handle the nerve as much as you can. An article here from Switzerland, if I'm not mistaken, what they did was they identified the phrenic nerve in the neck and they injected local anesthesia to it, and you can see a patient had a prolonged air leak and a basal pneumothorax, and after they injected it there, the diaphragm elevated and it kind of did a continuous block over there, and after a few days they could remove the tube for the patient, and the diaphragm regained its function after a few days later. Some other papers have written out is they've injected pneumoperitoneum. This is a bit more aggressive, where they placed air under the diaphragm and like this, and they caused the diaphragm to elevate. And some of them, some injected just 1 shot, 2 liters in. Some people actually put it into a valve kind of a system over here, and they continuously injected flow into it to get the diaphragm to elevate. So there are many tips of the tricks you can do, but I think as thoracic surgeons, this maybe is a little bit too interventional, but you can give it a go. And but these are just reports from certain centers. So the last one I wanted to come to is I wanted to show you a complication where it's bad, but it's salvageable. But what happened after that complication is something that is very problematic to deal with, in the sense that from a administrative point of view. So we had a thymoma over here. She had some effusion, but it was all okay. So this is what I did was try to do it again, my early days, and try to do it through a VATS incision. And so she's a non-myasthenic patient. So we thought, okay, let's just resect the thymoma, and just jump through the video of the thymoma resection. So we took the thymoma out, and so the guidelines basically say if it's a thymoma, you should do a thymectomy after it. I've actually just looked at some meta-analysis on it, and we've written it, but here comes the point. So we decided anyway to continue to just free up the whole thymus gland. So here we are trying to get to the superior fold, and we just put a clip there temporarily, and then using the ligature, we burn it, and this is what happened next. Okay, so big blade. So first thing to do is re-grab it, and again pack it, pressure and weight. But after multiple times of packing and trying to see packing fracture, we finally discovered this is the anomalous vein that we buggered, and that I buggered. And I thought, okay, look, what do we do next? So we put some pressure on it, and we did a median snorkeling for the patient. And what we found out is that the more we kept on pressing, this vein is very, very fragile. The more we kept on packing, the more we kept on tearing it more and more and more. So eventually we ligated the anomalous vein, and we came out, and the patient was okay. But the first thing I did at my level here was I called my senior to come in to help me very quickly. So it's very important you do that. Always, even at a very senior level, when you have this kind of bleeds, nothing wrong with calling in someone to help you. So anyway, we did that. But post-op X-ray, can everybody see what's going on over here? Patient's very well. I'll point it out to you. What's this guy over here?
There's a gauze left behind.
Yeah, exactly. and if anything you do, if you leave a gauze behind, it goes all the way up to the ministry, straight away. And it becomes a hospital issue and everything like that. So it's a big thing to do with. Patient, it was great. Family was fine. We didn't know where it was, so we just got an II when we put the patient on the table. I just put a ring forcep over there and did it through a VATS and just pull it out. patient did extremely well. She went home literally after 5 days, and everything was great. But that complication is something that I hope no one has to ever encounter, because it is difficult to deal with from an emotional standpoint of view, and also from a hospital standpoint of view. Before I conclude my talk, is that I wanted to tell you all about a medical ethics course that was in Singapore, and there was a senior resident or senior registrar in Australia, a gynecologist senior registrar in Australia, and he came and gave a talk on no-fault error reporting. He was actually a fighter pilot for 15 years, and he used to be a fighter pilot trainer in the British Armed Forces. And he was a senior gynecology trainee in Australia at the time. And what he did was he said that as a fighter pilot, a lot of times you go up there in the air, you make these mistakes, you almost crash the plane, then you land the plane and you tell everybody what happened. So it's something called no-fault reporting. They're not going to fault you for it, but it's very educational. So what we can do with this no-fault reporting is basically that the errors that are trapped basically in our operations are unlikely to be detected, because we can do that. We don't present our data. We just go home and say, okay, I've had no complications, everything is good. But I think it's important that we actually start presenting this commonly, because what happens is that if for the first time you are having an error, like he told me, he said he put a hysteroscope into the uterus and suddenly he was in the bowel. And then he said, oh my God, what to do? And then when he went back to the tea room, and when he was talking with his other senior colleagues, they're like, oh, this is the first time happening to you, is it? So, you can, if you don't report this and you don't talk about it with your colleagues and stuff, you can go down in flames. Or really, basically, if you can report it and you discuss it and you talk about it, you literally can, avoid, or even when you're getting shot at or when you're having these complications, you can still keep the plane alive or keep the patient alive. And that's very important to share information. So, very important basically with this no-fault error reporting is that we should always find a root cause behind the errors and not establish blame or liability. I think it's very important for us to have a non-punitive approach, and that actually stimulates us to go out there and share our experiences with people. So a wise surgeon once said, if you haven't got any complications, you haven't done enough. And I like Atul Gawande from his book, Complications. I think all of us should read this book. And one of his quotes was, if we want perfection without practice, yet everyone is harmed if no one is trained for the future. So you must actually speak about complications, speak about how you encounter it and how you overcome it, or how you didn't overcome it, and discuss it and never be shy about it. So with that, I'd like to conclude my talk today.
Thank you very much, Harish. My respect for you has gone up threefolds because this was the most honest presentation that I've ever come across. Thank you very much for addressing the young surgeons on this forum with a genuine presentation. You've put your heart and soul into it. And you've really been very honest, and you've put it out for all of us to see. When I gave you this topic, I think it took you at least 2 to 3 weeks to prepare this presentation.
Yeah.
And it is obvious. It is obvious. I can see the effort that you've put into this presentation. So hats off to you, and a sincere thank you from all these juniors, because you have really brought up some very important issues around surgery and being a good surgeon. So there are a few comments I'd like to make before we start taking any question and answers. So the first point is your last or second last slide, where you spoke about no-fault reporting.
Can you still see my slides? Or
yes, we can. Yes, we can.
Okay.
So no-fault error reporting is an extremely important concept. It is absolutely part of your training, and it is part of your everyday duty. In the UK, the word that is used is duty of candor. Please do not forget this. Please write this down and Google it. Is DUTY, duty of candor, CANDOUR. And it is an integral part of risk management. And duty of candor states that whatever happens, you have to have a sign out and you have to identify what went wrong, what went well, and most important in no fault error reporting is that you must tell the patient what happened. It's not just about telling your colleague what happened, but the patient has to be informed about what happened, and you have to document that you have actually told the patient what happened. So sometimes, we think small things and we just say, it's okay, but it's not okay, whether the patient is affected or not affected. And I'll tell you, when you tell the patient what happens, 99% of patients actually respect you for it. And medical complaints go down. There is a paper which has looked at this, and there is a direct correlation between the honesty and the openness of the surgeon to decrease in medical complaints. Nobody minds it if things go wrong, as long as they feel that the surgeon has been honest and is on their side. You agree, Harish, on that?
Absolutely. I think without a doubt, from the beginning, when the patient comes to your clinic to the day they leave, if you tell them the truth about everything, they have nothing to blame you. But the moment you try to hide something and something comes out, they lose faith in you straight away. And that's when the losses start to come.
Yeah, and the important thing is the patient always knows when you're trying to hide.
Yeah.
That's the reality. I mean, if you think that the patient is foolish, I think you're mistaken. 99% of patients will know when you try to hide something. So don't think that the patient doesn't know. So it's always better to sit down with the patient, and also more important to sit down with the family and discuss all these issues. So that's a very, very good presentation which Harish has given us, which has given us clarity about how you should talk about your mistakes and how you must talk to patients. Excellent, Harish, excellent. Now, a couple of points I want to make. I like your slides on subcutaneous emphysema, and I like the fact that you showed us a YouTube video. But for the young people on this group, and Harish mentioned quite clearly as well, there is no role, and I repeat, there is no role for surgical incisions on the chest wall or for subcutaneous chest tubes or number 21 French needle or tube.
I've seen that. It's hilarious.
There is no role. Actually. Yeah. If you've got surgical emphysema, you have to get to the root cause, and the root cause is always lung. And so it is the pleural space that you have to drain. And he very clearly pointed out that the one reason why you're getting the surgical emphysema is because your drain is not able to handle the amount of air leak that is coming out. So the answer is either you increase your suction or you put in a second drain. Do not put in cuts on your chest wall. You will cause infection and you will end up with an empyema. That's the worst thing to do for the patient. The only person you're treating by making surgical incisions on the skin is the surgeon. That's it. You are treating the surgeon. You're treating the surgeon's anxiety, not the root cause of the problem. So very, very, very important point. And I like the way he showed it as well. The second point I want to make about bleeding is, remember when, most of the times we do the work and then we walk away, and usually the registrar or a junior surgeon closes the chest. So this message is for the registrar and junior surgeons. Imagine in your brain, what is 1 ml and 2 ml of blood? Okay, just imagine, what do you think is 2 ml of blood? Now, 2 ml of blood is probably 1 drop of blood. Agreed. It's probably 1 proper drop of blood. But if you look at leakage from an intercostal artery of 2 ml per second, then over an hour, it's 120 ml per hour. Do you realize that? It's 120 ml per hour. And if you multiply 120 by 24 hours, then it is a liter or liter and a half. Okay, or more probably, 2.5 liters. Because 24 by 120 is whatever. So the real key to bleeding is the intercostal artery. Everything else stops. The lung surface stops. Pulmonary artery, if it bleeds, it's a massive bleed. A small ooze always stops. But it is the chest wall which is the main problem for postoperative bleeding. And if you do not stop an intercostal artery from leaking, particularly a partially torn intercostal artery, then it doesn't go into spasm and doesn't stop. It continues to ooze, it continues to drip. And as I told you, just 1 or 2 ml a second is equal to 120 ml an hour. It's just a very simple concept. And so anybody who's closing the chest, if you see a leak coming from the chest wall, particularly if you're doing it by VATS, you can actually visualize it. Please put in a Liga clip or just buzz it off. You must stop that bleed, because most of the times when we go back in, we don't find a source of bleeder. And then you see, it's usually the apex of the chest wall, which is dripping gently. And then it's such a pain to go back in. It's a big setback for the patient. As Harish said, a mortality from a VATS lobectomy or a standard lobectomy is 1%. 1 to 3% is an international quoted number, but most of us who are doing a lot of it is 1%. And a mortality from a re-exploration for bleeding is 10%. 10% mortality. Can you imagine what happens? What happens is when you've got bleeding, you are completely upsetting the hemostasis and the physiological coagulation cascade. And then you get into a very bad cycle of bleeding and more bleeding, and then blood products going in and the coagulation products going in. So at the time of closure, you must make sure that the chest wall is not bleeding. And also look at the ports. Most of the bleeding happens from the ports rather than from the adhesion. And you didn't look carefully, you just said, it's all okay, and you went back. So 1 ml or 2 ml per second is the message I want to get across. Most of the bleeding is from the chest wall. If it's from PA and all that, that's a different scenario. That, we can't control that. That happens and shit happens. But the chest wall, we can prevent. And so very important to understand that. And the third point, which I want to make, Harish, is it okay? I'm just trying to sort of, get a few points across to these guys.
Go for it. I think this is important.
The third most important point I want to share with all my colleagues is, if you think of re-exploring, you must do it. That has been my experience. If the thought has crossed your mind that maybe I should go back to theater, do not look back, because waiting for 4 hours, 6 hours, 8 hours, 10 hours does not make the patient better. So, with experience, almost all of us have realized, then when the thought of going back in comes to your mind, if my registrar calls me on the phone and says, you know what, sir, I think we should go back. For me, that is the warning sign. And I will immediately try to put things into motion. I'll come and see the patient, but my threshold goes down. No matter who is in the team, as long as it's a decently experienced guy, if the thought of reopening comes into your mind, very little to gain by pushing time. Only thing that will happen is you lose more volume and you'll end up giving a lot more blood, and your results will get skewed. And so that's why I always tell my juniors, if you're worried and if you think it needs to be reopened, phone me and I will give you permission to start going to theater, and I'll get into the car and come. Always. This has been my experience over the years. Do you agree, Harish, in my third point?
Absolutely.
Yeah, very, very, very important that if you think of re-exploring, then just go and do it. And do it by VATS. You don't have to do a thoracotomy. Yeah. If you've done it by VATS, all you need is a camera in. I'll tell you, the advantage of re-exploration is when you suck all the blood out and you wash the whole camera, even if you don't find a bleeder, just by sucking all the blood out and cleaning it with, saline, hydrogen peroxide, betadine, whatever else that you do, you actually help the coagulation cascade. And it's very difficult to prove it scientifically, but most of us have seen that you don't find a bleeder, but just because you washed it all out, the patient starts to feel better and your chest still looks fine. And your chest drain, there's a reduction in the amount of blood coming out. So very, very, very important, okay? I love the fact that, Harish, you brought up the concept of herbal medicine. Yeah, it's such an important point. Never realized it, never struck my mind that there is so much data saying that these cause antiplatelet action. Very important.
Clinically, I've dealt with this. It's ridiculous. They just ooze, you know.
Yeah. I didn't
Ooze.
realize that they were so important. But you're right. You're absolutely right. And the other point I want to make is I personally in my practice do not stop aspirin. I'm quite happy to operate with aspirin because I feel that the guy is going to die because of a heart attack. He's never going to die because of oozing. So that's why anybody who's got a stent, who's got cardiac surgery in the past or whatever, I'll stop clopidogrel. I will stop warfarin, but aspirin, I say continue till the time of the surgery because we can control aspirin pretty easily on table by being careful and doing your dissection carefully. So I try to take care of the heart quite aggressively because my philosophy is you don't die because of oozing, but you definitely die if you get an MI on table. The last thing I want is a stent to go down. So excellent. Anybody's got any questions to ask? Another question which was raised in the group was you said early in your lecture that for you the X-ray the CT scan has to be at least 3 months old, and people immediately started writing about that. In our clinical practice, 4 weeks is what we tolerate. Unless it's a benign pathology like an aspergilloma or something like that. But if you're doing lung cancer, then 4 weeks is what we want for the CT scan. We don't want it to be later than that. Maximum 6 weeks, but most of the time 4 weeks is my cutoff. But that's okay. That's individual practices. How do you manage torsion, Harish? When
So actually, I had a brilliant patient and an X-ray. I wanted to put that in, but I thought the talk's getting too long. So I had which I managed from another colleague. He had a middle lobe torsion, this patient. So patient had upper lobectomy, had a middle lobe torsion. Post-op day 4 or 5, started having a bit of hemoptysis. Offered patient to go back in because there's risk of gangrene and stuff like that. And the patient said, no, I don't want any more things done. So we actually left it alone, and patient was fine. You know, and surprisingly, I mean, the reality is that the lung should die. And believe it or not, 3 years later, she got a recurrence of cancer in the lower lobe, and it was so we discussed the tumor board. They said go in and do remove the lower lobe, so we have to do a pneumonectomy anyway. So when we went in back in, this one I went in to do. The lower lobe is completely. Your middle lobe is completely gone. There's like nothing left. There was just a thin piece of fiber there, you know. Of course, everything was stuck down, but when we tried to really look for the lower lobe and try to define it, we couldn't. So, I mean, for any torsion, I would go back in straight away. I mean, there's no doubt about it. But I just wanted to show this case, but I thought, oh, it's a bit too long. I might push it too long. So, just one, but torsion, I would go in.
On table, do you fix your middle lobes?
No, I tried that once and I got a bad post-op ailing in an emphysematous patient. So generally when I get them to inflate the lung, I will put the scope, look properly and make sure it's going in the right direction. And if it's going in the right direction, I don't do anything. I've never fixed the middle lobe.
Have you ever tried bronchoscopic technique to relieve the torsion?
No, like I said, I've only had to deal with one torsion case, and that was a patient which...
So one of the options available to you when you've got post-op torsion or suggestion that you've got torsion is to do a bronchoscopy and suction it out really well and then get your bronchoscope into the middle lobe bronchus and try to, you know, suck it all out so that it may anatomy. It may work. It has worked in the past in a couple of patients. I've seen it being done. But torsion is a real problem, and usually with torsion you need to reoperate. The problem is the moment you have torsion, then you've got gangrene, and gangrene then causes sepsis. And that, you know, you were lucky to get away with your patient who had torsion and fibrosis, but tissue lying there with pus in it makes the patient systemically unwell. And so that's why you should look to operate, as he said correctly. Anybody's got any other questions to ask to Harish? I mean, it's just an amazing lecture. Beautiful, Harish, beautiful. Any other questions you've got to ask, guys? Oh, you must have done a very good job. No, excellent. I really enjoyed it, and beautiful cases you brought up, and this is going to add value to the Thoracic Guru's YouTube channel. Excellent.
Thank you.
So, yeah,
Thank you.
we've had about 21 people logged in today on this platform, and another 13, 14 on the YouTube platform. And I haven't seen the international response just as yet. So we had about 40, 50 people. So excellent.
Wonderful.
And then, of course, people are following up these videos on YouTube. A lot of people are not watching them live, but they're following
Yes.
them up on YouTube.
Yes.
Harish, congratulations. We have had 25,000 views now on
I know.
all our
Well done.
series.
Seriously.
So we have crossed the
Congrats.
25,000.
Seriously.
I'm serious,
That's amazing.
25,000 across 50 countries. I got all the feedback,
amazing.
and so it's just.
You know,
I mean,
I
I
don't
didn't
even
even
know there are 25,000 thoracic surgeons.
absolutely. I didn't even know there were 25,000 thoracic surgeons in the world, but we have got 25,000. We have crossed 25,000 now.
Well
Till
done.
2 days ago, we were at 25,563, but today we have gone beyond 25,000. So well done
Brilliant.
to all of us. And
Brilliant.
well,
I even directed my residents to say, hey, you want to get a thorough, no need to go to class, just go to YouTube Thoracic Gurus